Welcome to MRCOG Part 2 free webinar, and today we'll be talking about how to strategically start for MRCOG Part 2, and we'll be discussing Green-top Guideline number 76, which was published last year, Thyroid in Pregnancy. It's an extensive guideline, but I have tried to include the most important points which may be helpful for your exam preparation. So I am Dr. Rubab Khalid. So all of you know me. I am the director and mentor at RK4 courses, and I maintain a free blog also in which I try to share the relevant resources for MRCOG as well as other postgraduate OB/GYN exams. So the agenda for today's webinar is we'll be discussing about the MRCOG Part 2 exam format. Some of you are going to take it for the first time, and most of the people, they have taken the exam previously. So you do have the fair idea about the exam format. So I'll be just giving you a brief outline what the exam format is and how to know about it. And the most important question and the most important thing which I want to focus on today is that how to prepare and how to start for the exam strategically. And if you have taken it previously, what are the things you need to change in order to successfully conquer this step of MRCOG. Then I'll give you a brief outline about what are the courses available and how you may get benefit out of those courses. And then we'll be discussing the thyroid disorders in pregnancy guideline. And in the end, I'll take your question and answers. And I hope some of the concerns you guys have shown me just before we started, hopefully those things will be clarified, and at least you'll have insight that what are the things you need to do to tackle this successfully. So let's talk about the exam format. This exam is now a computer-based exam, and it's a written exam. So it is very important to be well-versed with the technology and to know how to tackle the computer. And this is the basic skill. Some of the people who are 40 plus, and if they are taking the exams, they might not be very familiar with the computer and all that. But for this exam, you need to get to know about this, managing it, handling it, and not panicking, getting yourself used to of reading on the computer screen. That is also very important, because we are all used to of studying in the paper and pen based models. And when it comes to the screens, some people, they struggle. So you need to condition yourself about that. So there are two papers, paper 1 and paper 2. Both the papers, they contain 50 SBAs and 50 EMQs. So each paper is for 3 hours or 180 minutes. So college recommends that you should be spending 110 minutes for solving the EMQs and 70 minutes for SBAs. The reason I'll show you in the next slide, because even though there are 100 EMQs and 100 SBAs, but the weightage of the extended matching question is way more than the SBAs. So that's the thing. And let's talk about it, that the SBAs, its weightage is about 40% of the exam paper. Okay, so if you have solved 100 SBAs in both the papers, that is just the 40%. And EMQs are the 60% weightage for the exams. So now there is a basic difference between single best answers and extended matching questions. Single best answers are very straightforward questions. They are testing your facts. Like you read a guideline, there is in the beginning, there is an epidemiology portion. So you read that, they have given you some prevalences, incidences, some numbers, some facts which are related to the disease or related to the condition. So most of the time, those things are tested in single best answers. Whereas in extended matching question, that tests your in-depth knowledge, that tests your the clinical reasoning, the critical thinking part. So that is why we get confused. And there are a lot, I mean, in the single best answers, there are 5 options. In extended matching questions, there could be up to 20 options. So just looking at them and just reading them is too much. It takes a lot of time. But the key is, when you read the extended matching question, just read the stem, read the questions, make an answer, think of an answer, or probably 2 or 3 answers, and look for that answer in the given options. That is the thing. In single best answer also, questions also, you should read the question, formulate an answer. And sometimes, I mean, if you have no idea, but you can just look into those 5 options and exclude the right or wrong options, then maybe you can reach the correct answer. But for extended matching question, it is highly recommended that first you should have an answer and then look for it. And in extended matching question, the thing is that so many options are nearby, close. So you need to really understand your guidelines, master your guidelines in depth, so that if they ask you the question, you know, okay, this is the answer. And I know, I totally agree with everyone that extended matching questions are really challenging. But with practice, it's all doable. Trust me, it's all doable. And I'm sure that you will be able to do it by yourself. And I have 2 other slides also about the single best answer and EMQs. We'll be discussing a little bit more about those in those slides also. So regarding the syllabus, it is very, very important to gather and to know what exactly is going to be tested in the exam. And this syllabus is all given on the RCOG website. I get a lot of queries, especially related to my blog, as well as in my courses, because I have provided the reading material, the downloadable reading material. Those who have subscribed, they know that what I'm talking about. They it's always like, you know, everyone is asking me, is this all these things do we have to study? And my answer is no. But I give those reading resources and reading materials so that if you have to know a topic or something in depth, you do not miss it. You have everything on your fingertips. And if you go and check on the RCOG website, so you will know that in 2019 and then in 2024, they have made some changes in the curriculum on the RCOG website now. So what is happening is, they are applying the principles of adult learning and the medical education into the RCOG syllabus, and they are trying to make it in alignment with the GMC guidance and GMC requirements. So that's why this syllabus keeps changing, and according to the latest innovative ways of learning and teaching. So that is the reason behind it, why they keep changing it. And you need to, before you start preparing, even if you are taking the second attempt or third attempt, I would strongly suggest you to please spend some time on the RCOG website, read what is outlined in the syllabus, so you'll have an idea what is expected from you. If you do not know what the examiners are looking for, you will not be able to demonstrate it to them. So now they have changed some wordings, and now they call it as capabilities in practice. And there are like, they say, okay, a person who is at the level of MRCOG part 2 or part 3, they are regarded as ST5 trainee in the UK training system. And there are certain practices which they should be able to perform. So that's what they have seen. They have now reworded it. But remember, things have not changed. The core content of the syllabus, it is not altered. It is the same thing. I mean, if you are studying early pregnancy care, so you are expected to know about the miscarriages, ectopic pregnancies, the nausea vomiting of pregnancy, The gestational trophoblastic disease is ovarian hyperstimulation syndrome. So the content and the expected things, they have not changed and they cannot actually change. But yes, the way you approach towards those topics, that does change. And that is the reason I have seen that in the last couple of years, RCOG is bringing in new questions, and they are not repeating the questions now. And whatever the guidelines they are publishing or the talk articles are coming, they are incorporating into the questions in the MRCOG Part 2. And I'll tell you the reason. The reason is advancements in the technology and AI. No one would be talking about it because AI is a part of our lives. If we can use it, the examiners, the medical educators, they are also using it, and it's become a little easier for them to generate the new questions, to test them, and to map it according to the MRCOG syllabus, blueprint it with the assessment, and ask you in the MRCOG exams. So now just mere reading it and memorizing the numbers or memorizing the things or just doing the previous recalls is not going to be helpful. So that is also very, very important, that you should have the understanding of the exam. So now the modules are known as the knowledge areas, but we keep calling them modules, and that is not wrong. It's okay. So if you see now, they have previously there were 18 modules. Now they have compiled it into 15 knowledge areas, and you must know what are the knowledge areas so that you will be able to prepare it accordingly. So clinical skills, teaching and research. Clinical skills will be tested in MRCOG Part 3. Teaching and research, yes, we do have questions related to that. Then core surgical skills, post-operative care, antenatal care, maternal medicine, management of labor and delivery, postpartum problems, gynecological problems, subfertility, sexual and reproductive health, early pregnancy care, gynecological oncology, and urogyne and pelvic floor problems. So these are the 15 knowledge areas. And if you call them modules, that's also okay. If you call them knowledge areas, that's also okay. So no need to worry if you see these words on the RCOG website. Now coming to the exam resources, the most important exam resources from the Royal College. And if you go to the website, you get all these resources. You get the Green-top Guidelines, you get scientific impact papers, consent advice papers, clinical governance, good practice and best practice papers. And please, it is just note, whatever is given on the RCOG websites and these guidelines, they are the very first thing you should be covering whenever you are preparing for the exam. You cannot go to the exam without covering the RCOG guidelines, full stop. I will not say anything more than that. If there is a guideline, you have to do it. And there are about 76 guidelines, as we are going to discuss the GTG 76 today. So there are these guidelines, and you really need to know those guidelines by heart. And I will tell you, as we practice today, you will know that how to pick the important points from the guideline. Then the second most important resource is the NICE guidelines. So NICE guidelines, there are a lot of NICE guidelines. I mean, they produce national guidelines for all subspecialties. For the gynae obstetrics, we have around maximum 20 guidelines which we need to cover. And when you're reading it, if you want to search, just search on the net, and you will know that what are the guidelines which are covered in the NICE related to the obs and gynae. Then we have co-SRH, previously which was called FSRH. Now, this has become the College of Sexual and Reproductive Health. So we have the contraception guidelines. All the guidelines are given, and again, there are around 20 to 25 guidelines related to that. Those you have to read and have to understand. Reading these guidelines once would be enough because they have very good executive summaries given in the beginning. So you just have an understanding, just note down the important points. And when you are revising it, you can revise the executive summaries. That would be enough. Reproductive health related issues can be covered from the BASH guidelines, which are related to sexually transmitted infections or other things. So the BASH guidelines are also important. Then very, very important, TOG articles. So if a topic is not covered in the RCOG guidelines, NICE guidelines, COSHRH guidelines, BASH guidelines, then the TOG article is the best resource for that. For the exam, it is recommended that you should be covering at least last 3-year TOG articles, and you should read them cover to cover. You should understand and learn them by heart, because most of the times the people who are in the examination committee, they are a part of the TOG editorial board also. So if there is a new TOG article which is related to your topic, just skim it, just have the important information and add it to your reading material. And moreover, embrace reports related to the maternal mortality, they are also important. And at least you should have the executive summary or layman summary of these reports of last 3 years. And they are just like 4 or 5 pages per report. So if you compile them, that will be around 20 pages maximum, which you have to cover by as a minimum for the upcoming exam. And then we have the NHS colposcopy screening guidelines. So at a glance, it looks a lot of things, but do not worry. I have compiled them all on the RK4 LMS courses, as well as all these reading materials are compiled module-wise in my free blog also. So you can get from there and you can have an idea what to study for a particular topic as well. We can emphasize a little bit on the Green-top guidelines, which I call them the Bible of MRCOG exams. It would be a great sin if someone goes to the exam without reading the Green-top guidelines, okay? And you have to understand these guidelines and you have to understand those. And the appendices, the tables, the charts which are given in the guideline, they are very important. If you have noticed the latest guidelines, they are providing the executive summaries also in the beginning. So they are of a great help for everyone. So when you are revising, especially in the last week of exam, you can revise those summaries, and most of the time, most important topics, they come from there. So we do have all these guidelines compiled in the written summaries or in the video summaries, or you can get them all the summaries, the bulleted summaries, the important points in the e-course as well. Continuing with the exam resources, TOG articles, as I said, that the topics which are not in the guidelines, they are to be covered from there. And scientific impact papers, they are also becoming important in the recent times. Because if a topic is not given in the Green-top guideline or in the TOG article, you can read it from scientific impact paper. And when it comes to deciding about which option to choose, if a topic is given in the TOG article and in the scientific impact paper, I would go with the scientific impact paper figures, because that is directly from RCOG. So that carries more weightage than the TOG articles. So you need to categorize the exam resources in terms of priority. The first priority, Green-top guidelines, RCOG guidelines, NICE guidelines, then TOG articles, FSHRH, and BASH guidelines, as I have talked about. So we have all the TOG articles, written summaries also available, which are about 130 plus TOG articles, last 6 years plus articles, and they have been updated till January 2026. So you can think about those as well. Now let's talk about the books. These are the books which are commonly available in the market, and they are in the market for quite a long time. And I would suggest you to kindly practice these books, but there is a big but here. If you think the publication date is too old and a new guideline or a new resource is available in the market, please cross-check the answers. That could be a mistake, because these books are now old. Their editions are becoming old. They are old, and new materials are there. So always cross-check with the latest guidelines and latest material. Out of all these books, I would strongly suggest two books. One is this book, this SBA by Amanda Johns, because this is from the RCOG, and there are some questions which do come in the exam as copy pasted. So you must do this book. And then this book, SB and EMQs for MRCG Part 2, Tahir and Datta. So these two books are strongly recommended. I strongly recommend to do at least these two books, because when you do these books, you'll have a fair idea how SBAs are structured and how extended matching questions are structured, and you'll get a good practice from these books. Now comes the question, how to prepare for MRCG Part 2. I know whenever there are so many people out there, and you may have attended previous webinars also, and everyone keeps repeating the same thing. But I just want to tell you important points. First thing is to understand the exam, as I have given you a brief idea how the exam is made and what are the reading resources. You should plan it. Without planning, you can't do it. And you have to give adequate time to it. At least 3 to 6 months of sheer hard work and dedicated time is needed to crack MRCOG Part 2. And it's not just that you say that I'll give 6 months, but you have to do something about the exam for those 6 months, and you should be doing it every day. Do something every day. Consistency is the key to pass this exam. If you have taken the January 26 exam and you are wondering whether to take July 26 exam or postpone it to January 27, just think about your own circumstances. What is your job? What are your family circumstances? What is the situation of your kids? Finances? Can you give time for the exam preparation? Can you give dedicated time to it? And then think of it. Because if you say, okay, I'll appear in January, but you do not do anything for all these 8-9 months, what's the point? But if you have taken the exam in January, maybe you scored, but you studied, and if you continue that momentum, maybe you'll get through in the July exam. So this question is a very personalized question, okay? So once you decide, okay, you have to take the exam, gather the reading material, and I would suggest to gather the reading material in the soft form, not in the hard format, because if you have it in the soft form, it is easier to update and to change it. Because if you get the printouts, if there is a change, you will have to get it again and go green, right? And save the planet, also save the paper, and just use the technology, and that would be helpful to you. Organize them, as I've told you, module wise and according to your schedule. Schedule is very important. You have to make, like if you are targeting July exam, after this webinar, sit today, take 2 days and make a strict schedule. How you are going to cover all those 15 knowledge areas for the MRCOG exam, and how many days are you going to give to each knowledge area, and what are the important points you will be covering in those, and how you will be doing it. Okay, maybe you are doing a extensive guideline and you dedicate 1 day to it, but the next day you are doing some small articles so you can take a rest. So you have to have a full schedule and keep some time for emergency situations also. Keep some days off just in case you get unwell, or there is some emergency in the family or something like this. So you need to have some rest days also, so you can adjust your schedule. Otherwise, if you make a very difficult schedule, it will be difficult to catch the missing parts, because the time is running short. Very, very important thing is you must make your own notes. No matter how many courses you join, no matter how much resources you have, until unless you have a notebook with you or in the soft form, you must make your notes. And there is a trick about making the notes. Don't write everything which is given in the guidelines, and don't just copy paste from the guidelines. If you have a good grasp on some topic, just write those points in the notes which you think you might forget, so that next time when you are revising your notes, you will be focusing on the things which you might forget. Because what happens, we keep reading, we keep revising those things which we already know, and we think we know it all. And that's the biggest trap for the exam, right? So if you have read 25%, you know, next time when you read, you will remember those 25% and you will be like, okay, I'm done. I think I know this guideline very well. What about that 75% you didn't understand previously also? You didn't understand now also. So if you make notes, keeping this in view, that it will help you in revision, that's going to be helpful. And no courses, mark my words, no courses, no AI could be an alternative for your handwritten, your own made notes. Because if you have something like, if I've given any material in the course, that is my understanding. That's my understanding that what could be important for MRCOG Part 2 candidates. But what should be your understanding? That how would you be grasping that concept? How would you be reproducing it mentally in your exam? So that's the important thing. Practicing SBAs and EMQs, I can't emphasize more on that. But when you practice the SBAs and EMQs, you must practice them strategically. Because if you have done an SBA and you find the answer is correct, you must read and you must think and reflect on why the answer is correct. The why portion of your exam preparation is very important. If it is wrong, then read that why it is wrong. So if you think like this, then you remember. It's not that you have practiced 2000 EMQs or 2000 SBAs and that's a guarantee that you will pass. No. And sometimes when you practice the same SBAs and same EMQs in the same sequence, you may even memorize the answers without knowing the logic behind that answer. So please focus on the logic, that why this answer is correct, why this answer is incorrect. Then you will be, that practice will be a targeted practice, okay? Now, why we, like, sometimes we say that, okay, we have prepared and we feel that 70 to 80% of preparation is wasted, because MRCOG Part 2 exam needs a different kind of approach. It's not just that you read, you memorize, you just go and reproduce like in MRCOG Part 1. Part 2 is like, it's just that you have to have a deep grasp on the subject. It's a depth, it's in-depth exam. It would be like, you know, once you pass the exam, you will feel that they have tested your knowledge as if you have to dive in deeper into an ocean and get that knowledge out from you. So it's not just that you're just reading, you have to think, analyze, and then apply that knowledge and then come up with an answer. And especially that is true for EMQs. Now, for the SBAs, I told you what should be the strategy. You read the question and just see what is the clinical priority, what are they asking you, and then think, okay, which guideline can you apply on it? And whenever you are applying any guideline, is it Green-top Guideline, NICE guideline, do not forget about the clinical governance principles, which out of which the most important is the patient safety. Is this safe, what I'm offering to the patient? And then follow that and look at the options. Okay, this is wrong, this could not be correct. And maybe you will be easily reaching two options which might be closely related. And then again, read it. And then which is unsafe, incorrect option, just eliminate it and choose the single best answer. So this is a way of, process of elimination. Elimination technique is the one which is used in the SBAs. Now, regarding the EMQs, I told you, read the theme first. What is the question about? You know that, okay, this is a question about infections in pregnancy. So all the stems would be related to that. and then look at it, what they are asking you. Are they asking about the diagnosis, investigations, or management? And then see what is the important one. Focus on the words. Immediate management, most appropriate management, best management. And if you are confused about an EMQ, just flag it, move ahead, because time management is very important. You have to finish it, and do not forget to come back to that question before you submit your exam paper in the computer. So the strategy for the MRCOG Part 2 is that you need to have an active reading. It's not passively reading. You need to read, understand, think, reflect on it, and then it will be helpful for you. Keep practicing. Do not panic in the last month. Be consistent, and do not forget EMQs carry more weightage, so you need to divide your time accordingly and schedule your study. Follow that strictly religiously and focus on the why, not just the what part, right? And now coming to the July exam, you need to have the timetable in front of you. Expression of interest will close on 24th March. So you need to send that before it to RCOG if you are intending to sit for July exam. Booking window will open on 21st of April, and that is very important because the booking slots, they are filled in very, very quickly. So you need to be prepared and try to catch the seat. And do not forget, the exam is on 1st July. So how can we help you before we start with the thyroid guideline? So we have different courses. We have MRCOG Part 2 live course, master prep course. Then e-course, it's a written course. It's one of the most comprehensive courses we have to offer, and it's updated till as of today, 16th February 2026. And there are some essential video course and where I have recorded all the important guidelines in the interactive video format. And you can get all these courses in a bundle, and that would be saving you a lot. And as I mentioned, TOG articles, summaries, Green-top Guideline summaries, and we have a comprehensive question bank also, which keeps updated. So Master Prep live course will be starting from 3rd March, and that is the tentative schedule. So you can look into that and you can contact me if you are interested to join in, and you can see all this. We'll have around 17 to 18 sessions. So how can this be helpful? It's a comprehensive course which will be for about 4 months. And remember, it's a revision course. So that means your baselines should be completed before you join in this course. Then we'll cover all the important exam topics, Green-top Guidelines, NICE guidelines, FSRHRS guidelines. Then there will be an important session, special session on clinical governance and teaching. Session recordings will be accessible until the exam day, and we'll have a study group where you can clarify your queries. So a little bit more about other courses. So you can just go through this a little detail about what each course offers. And this is about the video course. This is the ultimate bundle. You can get all these 3 courses in one go, and that's the best offer you can have it. And talk written summaries, question bank. We have around 2000 plus SBAs and EMQs for extensive practice. So GTG green written summaries and the video summaries. So any questions so far before we start the thyroid in pregnancy? Yes, Sumaya, do you want to say anything?
Ma'am, I have a comment that I
Yes.
took the e-course, and
Yeah.
I think the course content, it is really wonderful. It supported me a lot, and I think I did not have the full prep, but I was comfortable reading the materials, and whatever I read, it was easy for me. Thank you for the course.
Okay, welcome. And I hope you'll get through because you didn't get time to read it really and you didn't have much time. So it's okay. No need to
Yes,
worry.
ma'am. Yes,
Okay.
ma'am.
So, okay. Thank you. Thank you. Right. So let's start with the Green-top Guideline 76, which is about thyroid disorders in pregnancy. And this guideline was published in 2025. It's a new guideline, extensive guideline, and a very, very important topic. Previously, this topic was covered under the TOG articles, which were quite outdated. So now let's do this guideline, and I hope this will be helpful to you. So before we start this guideline, there is an important table in this guideline, which is about the thyroid function disorders in pregnancy. So we may have hypothyroidism, which could be further subdivided into overt or subclinical. So you can see basically these are diagnosed based on the TSH concentrations and free T4 concentration. So you can just go through this because we'll be discussing everything in detail in the upcoming slides. So this table is important, and you can get this table as a part of assessment in single best answers. They may ask you about the prevalence in pregnancies and the TSH and T4 levels. So they may give you T3, T4, T4 and TSH concentrations, ask you to identify whether it is OH or subclinical hypothyroidism, or they may simply ask about the prevalence. Then we have the isolated hypothyroxemia. Then we have hyperthyroidism, which is gestational transient thyrotoxicosis, or overt hyperthyroidism, which is known as Graves' disease. Another condition is subclinical hyperthyroidism. So if you see, there are 6 main thyroid disorders which we encounter in pregnancy. So we'll be discussing about those. So why thyroid disorders are important in pregnancy? That is the question, the key question. Pregnancy is a stressful time for the thyroid gland because thyroid hormone production should increase by approximately 50% to meet the increased demands. And if thyroid is not increased, thyroid hormone production is not increased, fetal neurodevelopment will be at risk because fetus is totally dependent on maternal supply of thyroid till it starts producing its own thyroid. So 50% increase in the thyroid hormone production. This is an important figure. You may get it in the exam. So what happens for the thyroid hormone? And these are the thyroid hormone dynamics. So as the woman gets pregnant, the HCG levels increase. And we know that HCG has alpha subunit and it has a beta subunit. Alpha subunit of HCG is similar to the TSH. Okay, so once that HCG levels are high, the TSH levels, they are reduced or they are suppressed, and this is a physiological phenomena what is happening. So as a result, free T4 levels, they start increasing in pregnancy. So for the pregnancy, we should be using the pregnancy specific levels for TSH and T4. Okay, so that is important. And the first 20 weeks is a critical period, especially till the 12 weeks period, because that is the organogenesis period, and the fetus needs adequate amount of thyroid hormones. So what happens in pregnancy because of this increased demand of thyroid hormones? Iodine requirements in pregnancy, they increase. Because of the physiological changes in pregnancy, there is increased GFR, so renal excretion of iodine increases. Fetal thyroid production will start at around 18 to 22 weeks. So till that time, fetal thyroid also needs iodine. and there is expanded blood volume, hemodilution is there. So that is the reason why the iodine requirements, they increase during pregnancy. And we know the most common cause of thyroid disorders is iodine deficiency. So what should we do about that? So there is an increase in demand, so we should increase the supply also. So how to increase the supply? The supply can be increased from the dietary iodine, and the sources of dietary iodine include dairy, eggs, marine fish. The target dietary iodine should be 200 to 250 micrograms per day. You have to note this figure down. Daily iodine should be at least 200 to 250 micrograms per day for a pregnant woman. And it should not exceed more than 500 micrograms, because excess would also not be acceptable. So we need to balance the iodine requirements during pregnancy. So what does this Green-top Guideline recommend? It recommends to give supplementations of 150 microgram potassium iodide daily. Ideally, these should be started 3 months before conception, especially in those women who are at increased risk of thyroid disorders. So supplementations are recommended. And this is a relatively new guideline, so you need to remember this recommendation. Now, talking about what does the guideline say about the screening? Should we be screening all the women for the thyroid disorders during pregnancy? And they have conducted various studies, various trials were done, and they have quoted a lot of trials in the Green-top Guideline. And after this, they have reached a consensus that universal screening is not recommended for all the pregnant women, because this is not cost effective, and treating the low risk women would not have any benefits for the child in the long term. So remember this. This is a grade A evidence in the guideline. What does the guideline recommend? The guideline says first identify the high risk population, and then you can do the targeted testing. Okay. So how do we identify the at-risk patient? So they have given a table. I'll show you the table in the next slide, but here are some of the important points which you can just take it from that table. Okay, these are the high-risk women and who should be screened. So take the history. If patient has history of some thyroid disorders previously, she has taken thyroid medications, there is previous history of surgery, there is history of postpartum thyroiditis, patient has goiter, or she has any prior history of head and neck irritation, she is at high risk. So you need to screen her. Autoimmune diseases. Patient has family history or personal history of autoimmune diseases such as type 1 diabetes, SLE, antiphospholipid syndrome, or family history of thyroid diseases. She is at an increased risk, so we'll offer her screening. And if she has previous history of miscarriage, preterm delivery, or infertility history, then also we'll offer them screening. So what do we do? If you have, like, a patient comes to you at the time of the booking visit and you identify these risk factors, so you will test TSH and T4 levels for her immediately at the time of booking. So you may have a question in the exam related to at-risk patients. There may be a scenario a patient comes, so-and-so primary gravida or para 0+2 with previous history of hypothyroidism or hyperthyroidism or type 1 diabetes. So what would you be recommending? So there will always be some risk factors given in the exam. There will be key, or there will be what I would say buzzwords in the exam. And those buzzwords are there for you to identify what's happening, and they will help you reach the correct answer. And this is the table number 2, which is about the same things, which is given in detail. And this is from the guidelines. So this should be in your revision notes because you have to revise this. And these, if any of the exam scenario has this situation or this background of the women, you need to offer her screening. Now let's talk about hypothyroidism. There are different 3 types of hypothyroidism which are discussed quite in detail in this guideline. So let's break it into small chunks, small pieces. The first one is overt hypothyroidism. So what happens in overt hypothyroidism? It is revealed, it is evident. When you do the lab test, you will have high levels of TSH and low levels of T4 levels. So that is evident, okay, the patient is having overt hypothyroidism. So this can have some risks. It can have an impact on the child's IQ. It can cause miscarriage and it can cause preeclampsia during that pregnancy. So that is why if a patient is diagnosed with overt hypothyroidism, we must treat her. One of the challenging condition is subclinical hypothyroidism. So what is subclinical hypothyroidism? Is that the patient does not have symptoms, but when you offer her screening or when you test her based on her risk factors, you find that her TSH levels are high, but T4 levels are normal. So we call it as subclinical hypothyroidism. And there are some categories and recommendation based on the levels of TSH. So if the level of TSH is more than 10 milliunits per liter, we have to treat it. And if TSH level is less than 10, but patient has thyroid peroxidase antibodies, you have to consider the treatment. And if TSH is less than 10, thyroid peroxidase antibodies are not present, no treatment needed. And by the way, this information is very important, and this can come as part of the EMQ stem in the exam. And you'll have to look into the results and have this as a crisp knowledge. Okay, TSH there's, so you will be treating, considering treatment or no treatment. Okay, now let me explain a bit what is the difference between treatment and consider treatment. So treatment is like guideline has recommended. Okay, treatment is you have to just give that start the treatment, levothyroxine, you have to start. But when it comes to consider treatment, that means you have to take a lot of other factors in view. Maybe you have to take her previous obstetrical history, you have to keep in view her personal medical history, and based on that you will be deciding whether you will be starting treatment or not. And so here is the critical thinking applied. Here is the MRCOG level knowledge is applied, where you have to decide based on your own clinical judgment. Now there is a third type of hypothyroidism, which is called isolated hypothyroxemia. So in this, what happens? There is normal TSH, but T4 levels are low. So what is recommended by the guideline? Do not treat it routinely, but all what you have to do is to recheck in 4 to 6 weeks. So all what I have given here is taken from this table, Appendix E of the Green-top Guideline. So you see this appendix is given in a bit of haphazard sort of a thing, but you need to learn these arrows and these further actions, because these kind of flow charts are the best resource for EMQs. Again, here it is simplified a bit, the same thing. Overt hypothyroidism, start levothyroxine. Subclinical hypothyroidism depends on TSH levels. If TSH is more than 10, you will strongly consider levothyroxine. If TSH level is up to 10 from upper limit. So what is the upper limit defined in the guideline for TSH in the this guideline is 4 milliunits per liter. Okay, so if it is 4, up to 4 acceptable, ideal is less than 2.5 TSH during the pregnancy and before conception. Up to 4, okay. More than 4 is in the upper limit. Up to 4, it's okay, upper normal limit, okay. So these two flow charts may be of help for you. Now, how to manage hypothyroidism? There is a very interesting rule mentioned in the guideline, which is called 25-30 rule. So you can just simply say, so when you have diagnosed a patient, when you come across a patient who has hypothyroidism and she's already taking levothyroxine, okay, so she's diagnosed case. Now she's pregnant. So what does the guideline say? The guideline says that you have to increase the dose immediately as soon as you get the positive pregnancy test. That should be approximately around 5 to 6 weeks of pregnancy. So 25 to 30% increase in the dose. So they have given two ways. They have said that either you double the dose on 2 days. Like, for example, patient is taking medicine on Monday, Tuesday, Wednesday, Thursday, Friday. She'll be taking the same dose. On Saturday and Sunday, you will make it double dose. If she's taking one tablet, make it 2 tablets. So that means the dose is doubled. So it is 25 to 30%. Another way of increasing the dose is look at how much she is taking. If she is taking less than 100 micrograms of levothyroxine, then you will increase 25 micrograms per day. So you will add 25 micrograms per day to her regime. Or if she is taking more than 100 micrograms per day, then you will add 50 micrograms to her daily regime. So they are both the approaches of increasing the levothyroxine dose are correct. And this is very interesting and very important fact which can come in the exam. 25 to 30% dose increment is needed. Now, there is a patient who is newly diagnosed during the pregnancy. So what to do? We have to start levothyroxine. So the levothyroxine dose will depend on whether it is overt or severe subclinical hypothyroidism. Then we will start with 1.6 microgram per kg per day. And if it is subclinical hypothyroidism, then we'll start with 1 to 1.2 microgram per kg per day. So you need to keep the goals in mind. The goal is to have TSH less than 2.5 in the preconception period as well as during the pregnancy. And you'll monitor TSH and T4 levels every 4 to 6 weeks until the patient is 20 weeks pregnant. So next slide is about the surveillance and monitoring. So we need to offer high surveillance till 20 weeks because fetal thyroid starts functioning at around 18 to 22 weeks time. So we have to have a high surveillance and check the TSH and T4. So we will repeat the thyroid functions at around 26 to 28 weeks and then repeat it at the time of delivery. Once the patient delivers, we have to revert to the pre-pregnancy dose immediately. Because as soon as the baby delivers, the thyroid requirements, they are reduced. So reverted to pre-pregnancy dose. And in the postpartum period, check the TSH after 6 weeks. This slide is very important, and this would be an important resource for many exam questions, the monitoring, when to repeat the TSH, what to do at the time of the delivery with the dose, and what are the treatment target TSH levels. So this is about the hypothyroidism in a consolidated form, what the guideline recommends. And this slide, the next slide, this one slide is the complete summary of what all I have spoken about. Everything is given in this one slide. Diagnostic criteria, what's the prevalence, what are the maternal and fetal risks, which I have not dived into. You can go through this. What is the recommended treatment, monitoring frequency, treatment targets, and postpartum management. So you can revise either the previous slides or just one slide, and your hypothyroidism during pregnancy is covered. Now let's move to the hyperthyroidism during pregnancy. So in hyperthyroidism, there are two important conditions. One is gestational transient thyrotoxicosis. The other is Graves' disease. And it's a challenge to differentiate between the two. So they have given one table which I'll show you in the next slide. But here, let's talk about some of the main differences which I picked up from that table itself. So GTT is because of HCG stimulation, as I told you, because there are the alpha subunit of HCG is similar to TSH. The features are that it can cause hyperemesis, there would not be any goiter, and there would not be any signs. So that's the feature, and this would indicate that this is GTT. And thyroid peroxidase antibodies are not present in this condition. The management for GTT is just supportive. No need for anti-thyroid drugs. We don't need to start any medicines for this. Whereas in the Graves' disease, it's mainly because of autoimmunity. So we have thyroid peroxidase antibodies are present. Patient will have a history of autoimmune diseases. She will have goiter. She'll have ophthalmopathy. She'll have some other symptoms as well. So the patient who has Graves' disease requires anti-thyroid drug treatment. So you need to keep this slide in your mind and have a clear distinction between both the conditions. It's very important. The key differentiator of hyperthyroidism is TSH receptor antibodies. If it is present, it's goiter, it's Graves' disease. If it is not present, it's gestational transient thyrotoxicosis. So this is a table which is from the guideline, table 3, and a very important table, again, must revise before you take the exam. So important thing here is the patient with gestational transient thyrotoxicosis may have symptoms of hyperemesis gravidarum in up to 60% of the cases. 60% of the cases. If you remember the hyperemesis gravidarum guideline, it's mentioned over there also. 60% of the women, they have abnormal thyroid function tests, so they can have GTT as well. So we don't need to do any treatment. Control the hyperemesis. The thyroid levels will also be normal. They will be also okay. So in Graves' disease, 50% of the patients, they have personal or family history of thyroid diseases. 90% of the times they'll have diffuse goiter, and the levels in the Graves' disease, T3 and thyroid peroxidase antibodies, they both are increased, okay? Because in hyperthyroidism, TSH is suppressed, right? But the thyroid hormones like T3 levels are increased. So you can see this. So this will help you in the diagnosis and to differentiate. A very, very important table. So now let's talk about the anti-thyroid drugs. We need to balance the anti-thyroid drugs, and we need to use safe anti-thyroid drugs. And this is very important slide. Preconceptually and in the first trimester, especially in those patients who are less than 10 weeks, we should use propyl thiouracil because it has less risk of teratogenicity. And if a patient is taking carbimazole and she gets pregnant, as soon as she gets pregnant, you should shift her to propyl thiouracil, and that should be done before 10 weeks because that is the crucial period of organogenesis. And in the second and third trimester, we can shift her to carbimazole because propyl thiouracil is associated with hepatotoxicity, and that is an exam question. Why do we shift her to carbimazole after second trimester? Because of the risk of hepatotoxicity. And the therapeutic target with antithyroid drugs is to keep the T4 levels in the upper half of reference range to avoid fetal hypothyroidism. So I told you that we need to balance. We have to give the antithyroid drugs, but we should not be exaggerating it. We should not be giving it too much. So the fetal hypothyroidism occurs, and that's not the ideal situation. So how do we monitor the baby in Graves' disease? The risk is, what's the main risk? As I told you, the main differentiating factor for the Graves' disease is thyroid peroxidase antibodies. So thyroid peroxidase antibodies, they can cross the placenta, and then that can damage the baby's thyroid. So we need to monitor these patients who have active Graves' disease or who have history of Graves' disease or who have high levels, high titers of antiperoxidase antibodies. So how do we monitor it? And this is important. We'll test the antibodies at the time of the booking. And if the levels are high, we will repeat the antibodies at around 20 weeks and 28 weeks. We should be doing the ultrasound surveillance also, and we'll start the monthly scans from 26 to 28 weeks. And we should be looking for the what will be looking for the baby. We look for the goiter, we look for the tachycardia, fetal tachycardia, and we look for the growth restriction. So that's how we follow the patient who has Graves' disease. Now coming to the postpartum period. Postpartum is also important. After a patient delivers who's having hyperthyroidism, we need to think of the medication adjustment. As soon as the patient delivers, revert her back to the pre-pregnancy dose. Okay. And if the patient is diagnosed during pregnancy, you will stop the medications and then you will recheck it in 6 weeks' time. And what about the breastfeeding safety? It is safe to feed with levothyroxine in hypothyroid patients. Carbimazole can also be used. Up to 20 milligram is safe. Propyl thiouracil is safe up to 450 milligrams. So this is the drug management for the hyper as well as the hypothyroidism. And one of the tip is that we can split the dose and which the dose can be taken after the breastfeeding. Once a woman breastfeeds, she can take it afterwards in order to avoid the risks. So to summarize the hyperthyroidism of what all we have discussed, Graves' disease and gestational transient thyroidosis, this one slide, everything is given. This one slide is the summary for the hyperthyroidism, what all is mentioned in the guideline. One of a special case is postpartum thyroiditis. So that is important. A patient may have antibodies and after the delivery, in the first 3 months, she may have thyroid toxicosis and like she'll have flare after the delivery. So this is the first phase. So in this phase, there is destructive release of hormones. The guideline says that we should not use anti-thyroid drugs here. We should be vigilant about the postpartum thyroiditis. So these patients should be treated symptomatically, and this, we can use beta blockers for these patients. Then in around 3 months till the 9 months time, the patient may have a hypothyroid phase. The patient, like, once the thyroid is excreting a lot, after some time, it burns out and it stops secreting the hormones. So the patient goes into the hypothyroid phase. This phase is to be supported with the levothyroxine if the patient is symptomatic. And then between 9 months till 12 months post-delivery, patient may have a recovery phase. This is the triphasic postpartum thyroiditis, which is mentioned in the guideline. She may have a recovery, but remember, after postpartum thyroiditis, there is still 50% risk of permanent hypothyroidism. The very important exam question can come as a single best answer. And if a patient has postpartum thyroiditis, there is 70% chance that she'll have this recurrence in the next pregnancy also. That's also an important number. So these two thyroid disorders, which is postpartum thyroiditis and another isolated hypothyroxemia, I have not gone into the detail, but here is the one slide summary of all what is mentioned in the guideline and what is required for you for the exam. There is a special situation, 2-3 special situations that the patient may have, she's euthyroid, but she'll have thyroid peroxidase antibodies, like she does not have any symptoms. So what do we do? And this happens in about 5 to 31% of patients. It could be risky because it can increase the risk of miscarriages and preterm birth. So what do we do here? We don't do anything. We don't do anything. We don't give treatment. We don't do the routine screening. All what we do is surveillance. We just monitor this patient. we'll check TSH in the first trimester and we'll repeat it at 20 weeks. So this could be another special scenario for you. There are 3 other clinical situations mentioned in the guideline. I'll just touch on it in this one slide. They have talked about the thyroid nodule. If a patient presents with thyroid nodule, during the pregnancy, we can perform ultrasound that is safe, and fine needle aspiration, if needed, can also be done. If the patient requires surgery, it should ideally be done in second trimester. Now, thyroid cancer, very rare to be diagnosed during pregnancy. But if you have a case like this, management is multidisciplinary. Radioactive iodine is contraindicated. And if a patient has used radioactive iodine, she should not conceive for the next 6 months. It's also an exam question. For how long she should postpone her pregnancy? It's about at least 6 months after radioactive iodine. Postpartum thyroiditis, we have already talked about it. And one point to be added here, if a patient is diagnosed with postpartum thyroiditis, you should monitor her TSH levels every year. That's a point you can add to your notes. Some of the multidisciplinary team or designated roles and responsibilities of healthcare professionals and care pathways is given. This is Appendix C from the guideline. And just have a look at what you should be doing, because in the exam, whenever you have a question, always take it at a 360-degree view and involve the multidisciplinary team members, the other healthcare professionals, and follow the care pathways which are given in the guideline. And that makes a difference in your exam questions, okay? So this is the one slide summary of all the key recommendations that we should give. Iodine supplementations, 150 micrograms per day. We should do the high-risk group testing. Hypothyroidism management is that we have to increase the dose of levothyroxine 25 to 30% immediately once the patient is pregnant. For the hyperthyroidism, we have to distinguish from the Graves' disease. Shift the patient to propyl thiouracil in the first trimester and carbimazole from second and third trimester onwards. Make sure the fetus is safe and monitor it according to the recommendations. And in the postpartum, revert to the pre-pregnancy doses and check for the thyroiditis and monitor and repeat the thyroid function test in 6 weeks' time. So that's all. And I'll take some of the questions and answers. So let's conclude. Thank you very much for your time.